Hello everyone, welcome. Today we learn about RBC morphology. First we see the history. In 1678, RBCs were described as red blood corpuscles by Dutch scientist physician named Jan Swammerdam. And then Antony van Leeuwenhoek gave the detailed description of RBC in 17th century. After that, several other scientists discovered that RBC and WBC were seen altered in different disease conditions. Normal RBC is biconcave in shape, 7 to 8 micron in diameter. It has a flexible membrane with high surface to cytoplasmic ratio. Because of the biconcave shape of RBC, central one-third area of RBC looks pale and outer two-thirds of RBC looks hemoglobinized after staining. RBCs are the major cellular component of circulating blood. Average lifespan of RBC is about 100 to 120 days. Normal RBC size is comparable with the nucleus of small lymphocyte in peripheral smear. Morphology of RBC is evaluated in terms of size, shape, color, distribution, and intracytoplasmic inclusion. Abnormal variation in size is called anisocytosis. Abnormal variation in shape is called the poikilocytosis. First, learn about anisocytosis. Reduced in size is called a microcytosis. Increase in size means increase in RBC diameter is called the macrocytosis. And according to this morphology, anemia could be described as microcytic, normocytic, and macrocytic. Microcytic anemia are iron deficiency anemia, thalassemia, sideroblastic anemia. Normocytic anemia are anemia of acute blood loss, meroaplasia, anemia of chronic disease, and anemia of endocrine origin. Macrocytic anemia are of two types, oval and round. Oval macrocytes are seen in megaloblastic anemia, myelodysplastic syndrome, and in drug therapy like hydroxyurea. Round macrocytes are seen in liver disease and in excess alcohol use. Now we learn about poikilocytosis, means shape abnormalities. They are categorized as spiculated and non-spiculated. Spiculated RBCs have at least one pointed projection from the surface. Examples are helmet cells, Burr cells, acanthocyte, cystocyte, sickle cell, teardrop cells. Non-spiculated RBCs are the target cells, ovelocyte, stomatocyte. Let's learn about the individual shape abnormalities. First is helmet cell. They are type of cystocyte. RBCs having some inclusion earlier which was removed by macrophages of the spleen gives rise to appearance of the bite cell or helmet cell. They can be seen in microangiopathic hemolytic anemia, mechanical hemolysis, G6PD deficiency, etc. Acanthocytes. This type of RBC lacks the central pallor and they are having multiple but irregularly arranged spikes on the surface. It occurs due to the RBC membrane defect. Imbalance occur between cell membrane, cholesterol and the lipid content. They are seen in liver disease, post-splenectomy, in A-beta lipoproteinemia. Burr cells. They are also known as echinocytes. They are regularly spiculated RBC. They are mostly seen due to the storage artifact, but they can be seen in kidney disease, liver disease, or drug induced. Teardrop cells. Their shape is like that of teardrop. They are mainly seen in iron deficiency anemia, myelofibrosis, and condition associated with infiltration of bone marrow. Sickle cell. They are S-shaped or crescent-shaped cells lacking central pallor. Valine substitute glutamine in the sixth position of amino acid sequence in the beta globin chain of hemoglobin give rise to hemoglobin S. Under the hypoxic condition, polymerization of hemoglobin S occurs and this leads to sickling of RBC. Target cells. In this type of cells, the central hemoglobinized area is surrounded by a pallor and then again outer rim is hemoglobinized. This gives rise to appearance of target cells. Overall increase in the lipid content of cell membrane leads to increase in the cell surface area. They are seen in the liver disease and hemoglobinopathies. Spherocytes. These cells are darker, smaller than the normal RBC and they lack the central pallor. They occur due to the loss of the part of the cell membrane. So cell content to cell surface ratio is increased and this leads to the formation of spherocyte. They are seen in hereditary spherocytosis and in some acquired condition like hemolytic anemia. Macroovelocyte. The cell is oval shaped and larger than normal RBC. They occur due to the membrane weakness and this leads to increased fragility. They are seen in megaloblastic anemia, myelodysplastic syndrome, and in drug therapy like hydroxyurea. The difference of hemoglobinization in RBC leads to anisochromia. Hypochromia occurs when hemoglobinization decreased, and hyperchromia occurs when hemoglobinization is increased. Polychromasia means cells with many colors. They have shades of pink and blue and they are macrocytic. Other abnormalities are inclusion bodies and pathological distribution of RBC on peripheral smear. First, we learn about inclusion bodies. Basophilic stippling. They are denatured RNA fragments dispersed within cytoplasm. They show the coarse stippling and they are clinically significant. Second is Howell-Jolly body. They are the DNA remnants. Third is Pappenheimer bodies. They appear purple, blue dots and they stain with the Pearl stain. Fourth is Cabot ring. They are thin, thread-like arranged in the ring shape or in shape of figure of 8 and they are likely remnant from the mitotic spindles. Last variation is pathological distribution of RBC on the smear. First is agglutination and second is rouleau formation. Rouleau formation. The stacking of RBC one on another forming the rouleau formation. They are noticed in the normal smear if it is poorly prepared or if you are scanning on the thick part of smear. Abnormally seen when there is increased immunoglobulins and fibrinogen. RBC agglutination. Agglutination means clumping of RBC together. They are caused by the cold agglutinin most commonly. They are found in viral mycoplasmal infection or lymphoid neoplasms. Cell counter count the clump of RBC as a 1 RBC and gives false value of parameters like RBC count and MCV. So CBC should be run after the warming the blood at 37 degrees centigrade. So this is all about RBC morphology. Thank you.